Hello and welcome to Health Matters on Channels Television. We're so glad you could join us. I am Mary Alale Yusuf. A few weeks ago, we looked at maternal mortality, a topic very dear to the health community and included in the MDG goals, that's Millennium Development Goals. This week, we are interested in MDG 4, reduction of child mortality. Going by World Health Organization statistics, 6.3 million children under the age of 5 died in 2013, down from 6.9 million in 2010 and 8.2 million in 2005. Over 50% of these numbers are due to preventable or easily treatable causes. Some complications which contribute to the death of under 5s include preterm delivery, pneumonia, and birth asphyxia. The ratio of sub-Saharan deaths to those in developed countries is at least 15 to 1. 44% of child deaths occur in the first 4 weeks of life. My guest on the show today is Dr. Abidin Salako, a senior registrar of pediatrics at the Lagos University Teaching Hospital. You're welcome to the show.
Thank you.
So we're doing well. Looks like, or should I say we're improving, maybe not doing well, but we're improving. The numbers of children dying per year is going down.
Yes.
8.2, 6.7, now 6.3 in 2013. But we're not quite there yet, are we?
We are not yet there because going by the statistics, as at the onset of the MDG goals, we had 191 per 1,000 live births, that death per 1,000. But presently we're at 94, and we're expected basically to be at 30.
30. That would be three-quarters reduction.
Two-thirds reduction.
Two-thirds reduction.
From the baseline, as from the onset of about 191 deaths per 1,000 live births. The government basically has done at all levels, starting from the federal to states and to local government levels. They've done so much, basically, but more hands still needs to be on deck. Basically, we should thank them, but there are some factors that are drawing back. Most importantly, the issues of terrorism and wars up and down, either intra-tribal or the acclaimed religious issues all over the nation.
How exactly does terrorism contribute to child mortality?
Basically, when you have terrorism, you have absolute displacement of lives, of people and property. Basically, access to health facilities, all basic needs of life are also affected. And when you have this, now you have people being put in zones, in regions, or in homes where they can't be catered with. They're just giving some form of catering for. It's not a normal day-to-day life. So them accessing health facilities and them being cared for, them getting their immunization, them being treated promptly also becomes an issue. And apart from that, even the risk of disease outbreak, diarrhea, pneumonia,
is increased. But would you say that's our problem in Nigeria?
It is
at the moment.
It is part of the problem. It is part of the threatening factors. It is part of factors that might draw back the hands of Millennium Development, us achieving the MDG 4, basically. But other factors are there. The sincerity of the political class, basically, are they sincere? We can't see map out well outlined strategy, but sometimes the bureaucratic bottlenecks is more like duplicating offices, basically. They are doing, but those bottlenecks we need to break. Those bottlenecks we need to resolve. Then outside, we only see it within the urban setting. How much of the rural setting are we getting to? We need to ask ourselves.
Are you saying we're ignoring the rural settings?
We are, but more of life goes on in the rural area. And most of the time within the news, it's being pushed aside. We are only looking at the cities. But you need to get to those rural areas. You need to, how educated are they, how accessible is the health facilities for them, how easy do they get immunization. Sometimes you get to the health centers, immunization is not available, or is available, you are not even sure of the viability because of power issues. And if you look at, like you had earlier mentioned, the diseases basically that are killing our kids, especially the under 5, after the neonatal age group, and pneumonia, diarrhea. And malnutrition accounts for 50%. HIV/AIDS is also there. And so if we are not addressing this, which we feel immunization, empowerment of people that's giving them jobs, then also ensuring that there is a well-structured school health program within, no matter how poor the level of school is, which was there when we were growing up, but now the school health program is not there, which is supposed to cater for every child.
What do you mean by school health program?
The essence of the school health program is you meet every child at the point of, it's like the school at the point, you find out the problem of every child, and you can solve as appropriate, basically, either from the government perspective, from the own perspective. So you are not just in school for education. It's an holistic approach, basically. You come to school, but you get all in all. You get to look at the child from the health perspective, from the own perspective, from the nutrition perspective. But that is also been, some states are doing well with it. They are, but the thing is, you hear about it, it goes there again, you hear about it. Most of our program, the question we should be, or what we should be striving at, is sustainability.
Well, we seem to have achieved that with the polio vaccine, because they go to schools. It's like they have the way they operate. Yes. You know what I saw. It's like they have a map of the city or town wherever they're going, and health workers are dispatched to different schools during the weekdays.
Yes.
So in those days when my child was still under 5, and people would come to the house. Do you have a child under 5? And then she would say, no, they gave me in school, that kind of thing. So that seems to be pretty well covered.
There was a strategy for polio. And when Nigeria was part of the problems of polio, sorry to use that word, we are part of the pain of polio. But that's where polio is endemic. We were one nation that was militating against the issue of polio. There was a strategy, and that strategy was followed to the letters. And that's why today we have been able to achieve not much on polio. But despite that, we shouldn't rest on our oasis. We should continue. Even if we achieve 100% on polio immunization, we should continue. There should be sustainability after, basically.
What more can we do on polio? We have 6 wild polio virus cases, just 6. It looks like we could just wipe it out. Can we do that?
We can. If the government ensure dedication, to if we ensure peace among ourselves. It still goes back to what the displacement there, basically. And we ensure basic infrastructure facilities, good water source, hygiene, good power, basically. Power. Vaccines are not just going to be transported at normal temperature. They have to be transported and kept at
there's that as well. The vaccines could be there, but how viable can they be? They have to be stored at sub-zero temperature, right?
Sub-zero, yes.
And
they have to be transported at that same temperature, and also get to the site of use and subsequent use, basically.
At that same temperature.
You don't want it to break until we want to use it. So if you can't keep the temperature, which power is important, if you can't assure that a vaccine has been, a batch has been pushed out, we get to the location within the time schedule, then
is that why we have so many of the vaccines? Is it to cover up for these lapses?
Basically to cover up for the lapses, and also to ensure every child you meet gets the vaccine. You don't want a child missing the opportunity. Basically.
Okay. Let's talk about what we've done right. The numbers of mortalities have been going down.
Yes.
We must have done something right. What are those things?
We started right by Vision 2020, basically, and I think a lot was done. A lot of noise was made about it, and subsequently, the debt relief issue also. I think the immediate funds we got from debt relief issue was reinvested back into the system to ensure the achievement of the MDG goals, basically. Then also at the federal level, the SURE-P program on maternal and child health also was advocated, and every other state brought in. For example, Lagos State brought in the Child Act, and they are building a lot of maternal and child health hospitals. And they are training, whether at federal level, at state level, even at local government level, they are training of staffs or health workers, basically, to ensure expertise, skilled expertise in aspect of deliveries, and also in giving primary services to children who come with respiratory tract infection, diarrhea, who come for their basic routine immunization. They are doing so well. But some of the mitigating factors that is drawing us back is the perpetual strike with the health system, basically. The health system needs to be sincerely looked at for adequate health restructuring and definition of rules and duty. Basically, sometimes we get into the limelight for sometimes issues that if the government sincerely had resolved some of these issues, then there shouldn't be a need for incessant strike here and there. And that affects the common man. Because the question I ask you and we ask ourselves is how many people can afford the private setting? How many people? The bulk of the population still comes to the government hospital. So if there's perpetual strike within the government system, then you can imagine really the number of kids or even adults that go back home to die because they can't get adequate health care. Or they just patronize quacks. Because they can't.
Well, let's talk about things like malaria. Malaria and diarrhea, for example. Malaria has received a lot of attention. We've talked about insecticide-treated nets, talked about getting rid of stagnant water. Then almost every house has windows screened with mosquito netting. So why is malaria still one of the biggest killers? Then diarrhea. Almost every mom, okay, let me not say almost every mom, a lot of moms, let's put it that way, know how to make the basic oral rehydration solution in the house, even if there's no money to buy the prepared, the powdery form. Why are these still major, not minor, major killers?
There's major killers. For example, you say every mom knows how to prepare ORS, but the question is, the time limit.
Okay.
Where a child stops taking, where the child is no longer tolerating ORS, and you need to seek
medical attention.
Better medical attention. It becomes questionable. A child is at home, stooling and vomiting, the man is doing ORS. You're not seeing improvement. Then it's time to make a change. Basically, make a change and seek good health. But the question is also, if the mother wants to seek good health, does he have the funds?